Thank you, Ingham, and thank you everyone for attending this meeting. My talk is operative hysteroscopy, the time to move to office or outpatient. The philosophy of the patient ambulates in and ambulates out in contemporary hysteroscopy service is known to be safe, efficient, convenient, cost-effective by reducing theatre utilization and bed occupancy. Establishing such service requires investment in ambulatory infrastructure, training, and referral pathways. It also requires changing in the culture and mentality of practicing clinicians and increasing women's awareness. With advances in surgical technology, a number of gynecological procedures traditionally performed as a day case under general anesthetic can be undertaken in outpatient, and this is in keeping with the strategic vision set by the NHS delivery plan. The outpatient hysteroscopy service is well established in the UK and well ahead most of centers in Europe. I'm sure I'm not adding any new knowledge by presenting this study to you. All of us know that outpatient hysteroscopy is cost-effective to women, allows them faster recovery, less time away from work and home, and cost-effective to the NHS, reducing theatre utilization and bed occupancy. So what is the problem? The problem is the service in the UK in many centers is still fragmented. So some centers don't have dedicated unit for outpatient procedures. Some do the procedures on the local anesthetic in the day unit. Some offer diagnostics only, but not operatives in the outpatient. Some offer more sedation, but not ablation in the outpatient. Some don't have nurse hysteroscopists. Some don't have clear guidance and pathways. Some don't have dedicated team, where all consultants in some units have occasional hands-on sessions in the outpatient hysteroscopy unit. This increases the failure rate and conversion rate, and increases the follow-up rate, and also inability to manage as one stop. Hospital episode statistics in England from April to July 2020 during the pandemic showed 70% reduction in elective theatre procedures, but there was only 31% reduction in outpatient procedures. Therefore, to improve service efficiency, reduce backlog and waiting lists, we must move procedures out of theatre. And this is a lesson that we have learned from the pandemic. How to go forward? You might be aware of the National Day Surgery Delivery Pack and the GIRF guidelines of September 2020, which has been amended in September 2021. And key procedures have to move from day surgery to outpatient in gynecology, includes cystoscopy, hysteroscopy, evacuation of retained products, and endometrial ablation. You might also be aware of the British Association of Day Surgery BATS of September 2021, which was included in the GIRFIT report of September 2021. They set a target of 90% for diagnostic hysteroscopies to be done in office, and 50% of the operatives, including ablation. Of course, colposcopy is well established in the outpatient, but cystoscopy is also have been added and to the list. The objective of that move of the BATS is to shorten the care pathways for the patient, to speed up patient recovery and return to work, to free up surgical day case capacity for other procedures which cannot be done in outpatient, to reduce the number of elective operations cancelled, to reduce cost of treatment by reduction in theatre utilization and the staffing requirement, during the winter pressure, inpatient procedures are cancelled by us, but outpatient procedures are not. You might be aware of the new development in how the NHS work, and we are now starting to work as systems where every geographically close providers will work together as one trust. So in the area that I work in, the Black Country, the 4 providers, SWPH, Wolverhampton, Dudley, and Walsall, will be working as if we are one trust on 4 sites. So in the Black Country, we are in the process of developing 3 diagnostic centers that include gynecology. So one of them will be Sandwell Treatment Center, Sandwell location, when we move to the new hospital in MUH, and also Bilston, which cover Walsall and Wolverhampton, and also Castle Hill, which is related to Dudley Group. So more and more procedure will be moving to diagnostic centers in the community, so the service will be expanding. However, this requires venue that is fit for purpose. You can't offer 21st century service in a Victorian building. Health and safety compatible, have a reception area, waiting area, consultation rooms, treatment suite with integral changing cubicle, and recovery suites with recliners. You have to have the right staff, hysteroscopist, whether a doctor or a nurse, 1 staff nurse for equipment, and 1 healthcare assistant, which is your vocal local and the person who will admit and recover patients as required. You have to select your patient for such a service, a motivated one, not extremely nervous, well informed, provided with patient information leaflet that you produced in-house, not generic ones, consented for see and treat, and have something to eat. We don't starve patients anymore, and have no language barrier. You have to have your up-to-date policies and guidelines, referral pathways, analgesia protocol, procedure protocol, post-operative care, equality policy, patient information leaflet, and ideally, electronic medical records. I would like to present to you 2 sets of data from our real-life experience in SWPH over the past decade. The first, our milestones in SWPH was we have done the first outpatient hysteroscopy in 2001. It took 10 years to do the first NovaSure procedure, 5th of April 2011. This is in outpatient. First VersaPoint was in September 2011. First MySure in January 2017. And we were the first unit in the country to use the Omniscope, rely primarily on Omniscope in 2019, and we are in the process to introduce the mini resectoscope for outpatients and Sonata treatment for fibroids. The first set of data is about hysteroscopic morcellation. We use MySure, and 287 consecutive women undergoing hysteroscopic morcellation data have been looked at. We removed during the study period from January 17 to March 21, 554 pathologies. The majority of them are fibroids, some patients have both. It was retrospective data collection. We have, during that study period, there were a team of 3 consultants with a special interest in hysteroscopy and a nurse hysteroscopist, and some cases have been done by 2 trainees under supervision. So the same team performed the 287 cases. We sent an itemized satisfaction survey questionnaire to the last 110 patients during this study period. We give the questionnaire prospectively after finishing the procedure. The questionnaire used the visual analog scale from 0 to 10, and score 7 or more was used to mark satisfaction or pain or anxiety, etc. And the questionnaire, I'm happy, it is validated questionnaire, has been published, and I'm happy to share it if anyone wants to repeat the same exercise in their unit. There was no complications encountered in our group, and all women, 100% left the unit within 30 minutes. Survey completion rate was 100%. Only 7 women required 2-stage procedure given the vascularity or the size of the fibroid. The majority of lesions removed were polyps. Some patients have both. Our analgesia protocol include intracervical block 4 quadrant, or gas and air, or both. However, you can see that 20 patients, 7%, had none. So usually multiple patients with mild morcellation, some of them don't need analgesia. And actually, this figure up to last year, our data last year, which has not been audited yet, less and less patients having analgesia in the first place with morcellation. Although 17% of women reported severe pain during the morcellation procedure, this was short-lived, and only 5.5% complained of pain on discharge 30 minutes later. The level of pain during the procedure had no negative impact on women's satisfaction. I assume because patients are managed as one stop, so they are happy. They finished everything in one go, and they are just waiting for histology result. So this balanced it off, in my opinion. You can see that like 97% of patients said the procedure was adequately explained, and 95.5 found the procedure acceptable without general anesthetic, and 92.7 likely to accept repeating the procedure in the future if required, and 95.5% happy to recommend the procedure to their family and friends. There was no significant correlation between the pain experienced during the procedure and the lesion size or the operator experience. And the level of preoperative anxiety was positively correlated with the severity of pain. So the more anxious patients, more likely to feel the pain. After 22 years experience exactly in outpatient hysteroscopy, in my opinion, outpatient hysteroscopy doesn't cause pain as such if you follow all the right thing to do. Usually the anxious patient is, you have to work hard to get them through it. The level of preoperative anxiety didn't affect women's satisfaction after the procedure. The level of preoperative explanation and information given showed positive correlation with the level of acceptability, willingness to undergo the procedure again, and recommendation to family and friends, and had negative correlation with the pain experienced by women in discharge. So this is the key. What to tell patient, how to take them through it, what to tell them in advance, patient information leaflet, your vocal local, how nice is the staff, respecting the dignity of the patient, etc. The second piece of data, and we can feel free to stop me if I'm running over, about the reintervention and patient satisfaction rates following radiofrequency ablation. The technique that we use is NovaSure. So we looked at the data of 408 women from 1st of May 2011 up to 31st December 2017. 52% of patients have been done in outpatient and 48 as day cases. At the time, we looked at the data last on 31st of December 2019. On that date, 78% of patients had the procedure more than 5 years before assessing their data. Again, we sent a survey questionnaire that was posted to patients retrospectively, and we sent it 3 times because, like the area that we serve, probably the response rate is expected to be low. And non-respondents were telephoned by one of the nurses to ask them one question, not to go through the questionnaire, but to ask one question, whether they went to another hospital to have a further operation, hysterectomy or ablation. Because this is the primary outcome. The questionnaire relied on visual analog scale, again, because it is an objective way of assessment. There was no statistically significant difference between the 2 groups, outpatient or day case, as regards age, previous cesarean section, submucous fibroid, less than 2 centimeter complications, or surgical reintervention rate. The total surgical intervention rate in our cohort was less than what has been published before. It's only 13.2%, and I will give you my opinion in explaining this later. Most had hysterectomy, only 2 had repeat ablation. The median duration to further intervention was 1 year. So usually patient who will have another operation will have it by the end of the first year after the ablation. Women with available data was 83%, and women uncontactable completely, even by after 3 questionnaires sent by post and by telephone. 68 patients were uncontactable. Assuming the worst case scenario that these 68 patients all had hysterectomy somewhere else, which is of course unlikely, not expecting the rate to be different from the rest, but assuming the rate of surgical reintervention will increase to 27%. So still 3/4 did not have surgical intervention, but this is of course the theoretical assumption, not to be true. Some confounders, the 5 confounders that we looked at, none of them affected the outcome. So age was not related to surgical reintervention rate, and my assumption is, because if you look at our cohort, 84% of them were 40 years old or more. So selecting your patient for ablation has an impact. When you do ablation for women who are 30 and 35, they will come back with failed ablation and blocked cavity. You can't do anything about hysterectomy at the age of 35 because you did the ablation at the age of 30. So deferring the ablation to the right age increases the satisfaction and outcome. Cesarean section was not related to the outcome, and we have done the previous 4 and the previous 5 in the outpatient. The presence of a small fibroid doesn't affect the outcome, or didn't affect in our study. The setting was not relevant. So the reintervention rate in the outpatient group was 7%, and in the day case group was 60%, which was not statistically significant. Operator experience didn't matter as well, because the technology is automated. All the outpatient procedures were done by consultant with a special interest in hysteroscopy, 3 consultants. The rest of the cases, 16%, have been done by all generalists in the hospital, 13 generalists. The outcome wasn't different. However, the only thing is our data didn't capture cases of failed hysteroscopy or failed NovaSure. Sometimes the device doesn't initiate if probably used by a novel, but our data didn't capture this. But for those who had the procedure, it doesn't matter if they have been done by an expert in hysteroscopy or by a generalist. No single major complication in our cohort, irrespective of the number of cesarean section. 6 women were treated empirically with antibiotics for assumed postoperative endometriosis, 3 in each group. The number of respondents to the survey was 62%. However, there was no statistically significant difference between respondents and non-respondents as regards age, setting, previous cesarean section, or submucous fibroid. So even the 38 who didn't respond to the questionnaire, I'm not expecting their data would alter the results. You can see women reported subjective improvement in menstrual flow, 82%, satisfaction rate 82%, recommendation to family and friends 80%. In none of these parameters, there was a statistically significant difference between outpatient and day case procedure. I remind you, this study, the recommendation of the BATS, they recommend 50% of operative hysteroscopy to be done as an outpatient, and actually by 2017, 4 years before this report comes, we achieved 52% for endometrial ablation, so it is 2. This is our dedicated unit in SWBH. We have waiting area, and we have 2 procedures room with all any technology available or any equipment required for outpatient existed in the UK is in our unit. You can see the cubicle to maximize patient dignity when they get it changed, and the doctor's desk, and there is a recovery area. And this is our lovely team in SWBH, and it is about teamwork. It is not one-man show at all. The question is, ethically, can we justify subjecting women, especially those with significant comorbidities, to the risks of GA for hysteroscopic procedures if we can avoid it? Thank you for listening. The chair allowing me 2 minutes of questions if you have any.
So 2 things, Ayman. First is your 2% of patients who felt a lot of pain are very vocal, and there's a support group that are really putting pressure on the college and gynecologists in general to allow more under GA. So that's a comment rather than a question. My question is, a few years ago, one of my registrars looked at the women who had an ablation and then came back asking for a hysterectomy. Now, nearly all of them actually had adenomyosis on the hysterectomy specimen, and we could have picked it up pre-ablation by asking carefully about secondary dysmenorrhea and asking the ultrasonographers to look for adenomyosis, and selecting those patients out would have prevented double procedures. So I just wondered if you had a look at adenomyosis in your study at all?
No, our data didn't capture that, but the practice in our unit, although this is not published or documented, the practice in our unit not to offer endometrial ablation if the patient prime symptoms is pain.
Right.
So we offer it for women with heavy menstrual bleeding as the main symptom. That is why this is the second reason that we achieved low failure re-intervention rate, only 13%. We don't offer if the patient is in pain. We know it's not going to work, so what is the point? And also we do not offer it if the patient is too young. We try to persuade them to try IOS, etc., and push it until they are near the 40 to achieve higher results. Yeah, and also because just the time is short, I didn't present all the data that I got. We strictly follow the document of the college advice. It's not a guideline of 2019. It is available on the college website. If the uterus is more than 12 centimeters, because this is the manufacturer also advised, we don't offer it. So don't play with the technology if you know that it's not going to work. So if the fibroid more than 2 centimeters, don't offer it. If the uterine length is more than 12 centimeters, we don't offer it. So if you follow the instruction strictly, people insert even IOS with big uterus with up to umbilicus. They think it's going to work. It wouldn't work. So if you follow the guidelines, you'll get higher success rate. I always tell the trainees, etc., don't fail the technology, because you can make bad reputation about technology because you are not using it appropriately. That's what I think anyway.